مساء الخير. بسم الله الرحمن الرحيم. برحب بيكم جميعا. احنا النهارده معانا الاستاذ دكتور احمد شكري، استاذ جراحه مسالك الاطفال، جامعه القاهره، مستشفى ابو الريش. The talk of today will be on bladder exstrophy management by Professor Ahmed Shoukry, Professor of Pediatric Urology. Abu Rish Hospital is one of the largest hospitals in Egypt, and the flow of exstrophy in Abu Rish. Do you hear me? Shukri,
I hear you. I hear you quite well, yes.
And the Abu Rish Hospital is one of the largest hospitals in Egypt, draining lots and lots of cases of bladder exstrophy. So our colleagues in Cairo University in Abu Rish Hospital have huge experience in the management of bladder exstrophy over the past years. So Dr. Ahmed Shoukry will speak about the management of bladder exstrophy and will explain to us the tips and the evolution of experience through the past years. At the end, we will have Dr. Mohammed Ghonaimi, Professor of Pediatric Urology in Cairo University, Abu Rish Hospital also, and Dr. Ahmed Derwi, Professor of Pediatric Urology, Asyut University. They will be the moderators and they will receive your questions and discuss with Dr. Ahmed Shoukry. So welcome, Dr. Shoukry.
Okay. Bismillah ar-Rahman ar-Rahim. Good evening, everyone. It's my honor today to present to this distinguished group of pediatric urologists. It's quite a difficult subject to talk on in a short period of time. Let's put some expectations before we start. Bladder exstrophy is a big entity to summarize in just under 1 hour. This lecture is suitable for anyone with little experience or even with a deep experience in bladder exstrophy. I hope everyone will get some value, and the most important, I hope it opens questions for discussion after the lecture. I will not teach today, of course, how to do bladder exstrophy technically. However, I will try to concentrate to give a little bit of a short history of management of bladder exstrophy and its evolution. Our experience in Cairo University, we receive maybe around tens of cases each year. Some of them are recurrent, some of them are new cases. So I will present through the lecture our results, our features, and reality. Also, I will include some latest studies we have done in our center, and I will try to summarize our philosophy and management of bladder exstrophy. So I apologize in advance if some experienced pediatric urologist might find some slides a little bit for beginners. However, we have all expertise on this and today's talk. So let's start. Bladder exstrophy. I'm having a little bit problem of clicking next. Okay. As an intro, bladder exstrophy is, as we all know, is a little bit rare disease. We find like 1 in 10,000 cases, or maybe 1 in 50,000 cases. Male to female ratio is around 2.3 to 1. This is a survey I sent before we started our lecture, and included 4 questions. One of the questions was how many cases we see each year. Only like 25 urologists participated. However, it can give us a little bit of info on the experience we have regarding this bladder exstrophy today. More than 50% from the participants see around less than 5 cases. So we have maybe it's an indication that we have some like young urologists here. That's why I will include some basic info. The spectrum of the bladder exstrophy ranges from starting from the cloacal exstrophy. This is the more advanced stage of it, going through the bladder exstrophy and the epispadias. It affects different parts of the body, mainly the urinary tract and genital tract, also the musculoskeletal system as a defect we see in the abdominal wall, also the intestinal tract. However, regarding the bladder exstrophy, especially the classic one, we have the famous triangular defect in the abdominal wall and a short distance between umbilicus and the anus, and we frequently have frequent indirect hernias. Also, some of them have like cardiological problems. That's why we usually make like an echo whenever we see a newborn with bladder exstrophy. Regarding the male genitalia, we have like the anterior corporeal length is like shorter than 50%, and the diameter of the anterior corporeal length is 30% is greater. In the female, we have a short vagina, and it's usually displaced anteriorly, and a bifid clitoris and divergent labia and mons pubis. Regarding the bone abnormalities, we have an inferior rotation of the pelvis and 12 and 18% external rotation, as we see here from the picture on the right. The most important also is the musculoskeletal defect. The levator in eye is positioned posteriorly, 68 more posterior to the rectum versus 52 in normal newborns. Antenatal is diagnosed like when we do antenatal ultrasound, it can be diagnosed. Some countries do like abortion. However, in Egypt, we see a lot of cases we never do abortion for an exstrophy child. We have an absence of a bladder filling, low set umbilicus. We see the widening pubis and a very small genitalia. And sometimes it presents with a lower abdominal mass. Postnatal management. The most important thing is to cover the patch. We cover it usually with Tegaderm, and we do a physical assessment and ultrasound. And as I told before, we do also like an echocardiography for the heart, as we usually see some heart defects. What are our objectives in management? Usually the parents are more concerned towards the functional and cosmetic, and sometimes they talk about even having what about the child future, will he get married? These are usually real concerns, and the primary concern for the parents whenever they have a child with a bladder exstrophy. However, we as a urologist should always look for renal function and of course the restoration of the urinary continence. So we always have to put in mind that there are three main topics we have to put in priority: the preservation of the renal function, the restoration of the urinary continence, and the reconstruction of a functionally and cosmetically acceptable external genitalia. We sometimes meet the parents with the don't think about marriage now, or that's too early to think, but these are their concerns and we have to listen to them. Objectives, secondary objectives are like the minimization of UTI, decrease of urinary calculi, or reconstruction of pelvic floor, and creation of a new umbilicus. When it comes to timing of repair, the usual literature or the classic literature used to tell us like classic repair should be before 72 hours and or delayed whenever they present late. I will also present some numbers on when we see at our center the babies. Timing of repair depends mainly on many different things. When do you see the patient? The patch size, whether you do osteotomy or not, the post-operative morbidity, and the care the child will get afterwards. So this all should be put in consideration. The advantages of having or following the school of a delayed repair is it eliminates the emergency problem from the mind and the chest of the surgeon and the parents. especially as like results in the literature did not show advanced results regarding early intervention, especially if it's done in specialized centers. It limits the paternal anxiety and promotes bonding with the child and his mother. This is very important and crucial period for the child growth, and having like a breast milk early and bonding with his mother for a few months before going into this type of big surgery might be beneficial for children. It also reduces the anesthesia risk, and it allows the availability of the team, because management of bladder exstrophy requires a team of urologists, nurses, anesthesia, and post-operative management, and even orthopedics. That's why a team is a key word in management of bladder exstrophy. The advantages of the early, it can be performed without osteotomy. However, sometimes it lacks the adequate surgical experience or the setting to manage a bladder exstrophy unless you are in a center specialized. So better to wait. Well, it's every school or I call it school or philosophy or center experience has its own guidelines for management of bladder exstrophy. A successful primary closure clearly is a critical in development of urinary continence and spontaneous voiding. And success of results usually depends on the first trial of repair. The patch size also is a part of the decision we make regarding the closure. If it's a good size, we can close. If it's a small one, it's better to wait. Also, patches come in different sizes and shapes, sometimes with polyps, sometimes with, it's a very big patch and looks very clean and very inviting to close. However, when this is our results regarding the survey I talked about, because some participants joined us late and might not have the opportunity to join this survey. However, it was a survey I sent to the group of urologists participating here in this session, and it showed the preference of surgeons, or 25 surgeons, on the age of intervention. More than 40% answered that it's better, or their preference, to manage after 3 months. Also, the second was like 30% preferred to close before 72 hours. I will also talk about our philosophy in management of bladder exstrophy later. This is a quick history of the management of bladder exstrophy. It started, actually, bladder exstrophy was reported very early in history books. However, scientifically, the first maybe in the 50s, reported on, they used to do posterior osteotomies, then bladder closure and epispedias. Then came Jeff in the 1970s, and he was one of the, of course, leading figures in urology, and popularized the staged approach. However, staged approach back then used to close the bladder, then do the bladder neck with anti-reflux procedure, and later on the epispedias. Now, in the modern era we live here today, you can say that there are two main schools in the world: the modern stage repair of exstrophy and the complete primary repair. Let's talk about the difference. The modern stage repair of bladder exstrophy at stage 1, usually done after birth, and we close the bladder, abdominal wall defect, and epispedias repair, of course, in the girls only, and with iliac osteotomies, or bilateral iliac osteotomies. The stage 2, later at 6 to 12 months, we do the epispedias repair, and some centers use like testosterone cream or to promote urethral growth for a better management of epispedias. Stage 3, usually at 4 to 5 years of age, when they do bladder neck reconstruction and bilateral urethral implantation, and is performed when the child can participate in a voiding program. Bladder neck reconstruction should only be done. I'm talking here about the staged. Should only, and also these rules applies for the other types of closure, and I will tell you how come we do bladder neck in the complete primary repair later on. However, let's concentrate to I'll try to be focused here, that the modern stage, this is the third stage in the modern stage repair, we do the bladder neck reconstruction. When the child should do the bladder neck reconstruction, usually when the bladder capacity is more than 100 milli, and the child is ready to participate in a voiding improvement program. What's a voiding improvement program? Usually composed of a senior nurse, a child life specialist, child psychologist. That's why I told you that management of bladder exstrophy usually relies on a team and not a single surgeon. To be honest, I don't know if other centers here in Egypt have this type of program. However, in Abu Rish Hospital, we don't have this specialized program for voiding. It's usually composed, yes, of a nurse, the resident, and the senior doctor, and sometimes the nurse of the urodynamics helps in teaching that the child for the CIC with the association with the resident. However, we don't have like a special program like the biofeedback program, or as we see in other centers. The complete primary repair, to differentiate, the philosophy behind it was to reduce the number of surgeries done for the child. It's called complete primary repair. So you should do a complete repair, bladder closure together with epispedias and some bladder neck technique for the bladder neck reconstruction, and usually done below also 72 hours. And some schools now prefer to do the late closure after 3 months. The epispedias technique repair ranges or different between center and center. Some centers do the complete penile disassembly technique, also has its variations, and the modified Cantwell-Ramsey. As I told you, this lecture is not concentrating on the technique. You cannot learn bladder exstrophy from a lecture. You have to go to a surgery. I'm talking here about general rules more than a technique to be taught in a short lecture. Then some centers do the Kelly repair. The Kelly repair is usually closure of the bladder dome and hernia repair at birth. Later on, 3 to 6 months reconstruction of the proximal urethra with association with a very deep dissection for sphincteric tissue and penile lengthening and creation of penoscrotal urethrotomy in boys, and repair of the resulting penoscrotal hypothesis later on at 3 years old. There is also the Warsaw approach. It's a closure at the bladder and posterior urethra, pubis, and abdominal wall at the time of primary closure, with or without osteotomy. And when the bladder has achieved suitable capacity and the child is interested in continence, bladder neck reconstruction performed along with epispedias repair. Also, there is the Erlangen approach. When there is adequate bladder patch, total repair is done at 8 weeks of age. And when inadequate bladder, only is closed with bilateral groin exploration and closure of the pubis, epispedias, and no osteotomy. There are some centers, but I'm not aware of to name some now. They do like ureterosigmoidostomy and depend on the anal continence. However, it carries risks like increased risk of pyelonephritis, hyperkalemic acidosis, rectal incontinence, or urethral obstruction. There are some reports dating like 1996 is now like a late date. However, they reported on long-term results for minor sigma pouch. Whenever you do a ureterosigmoidostomy, the child deserves to do a yearly follow-up for fear of adenocarcinoma. This is a survey also, to continue our survey. Our survey showed that like more than 60% of the participants preferred the modern staged repair. And again, for the young urologist listening here, the modern stage is done on 3 stages, while the complete repair, theoretically, it's done in 1 stage. And I will say why it is theoretically in 1 stage. This is our protocol. I have to say that our protocol evolved throughout the years. That's why you might see some mismatch in the results, and it's an evolving process throughout the years regarding the osteotomy and regarding the technique of repair. However, for a couple of years now, we've been following this approach. Whenever you have an adequate bladder patch, a complete primary repair at the age of 3 months with tightening of bladder neck and complete penile disassembly, plus minus urethral detachment from the glands, which means that we don't do like the complete penile disassembly with cutting of the glands. We keep the distal urethral end attached to the glands, and if we find that it's if it's like stretching the penis or it's not allowing the bladder to go down deep into the pelvis, we cut the urethra from its distal attachment and put it deep down into the pelvis. The philosophy behind this complete primary repair, what we do, is not achieving continence at this age. The philosophy of the complete primary repair, what we do, is to allow deep dissection of the bladder in association with its urethral attachment as far deep down into the pelvis, not to tighten it too much because we fear of fistulas, penopubic fistulas. So the only way we, from our point of view, that we can have adequate dissection is to do a complete primary repair with detachment sometimes when hypospadic urethra to allow, as I said, deep dissection. Osteotomy, yes, we do osteotomy, bilateral anterior innominate osteotomy, and I will talk later on the technique and its evolution. This is when we have an adequate bladder patch. Okay. Now, what's next? We assess bladder capacity and continence at the age of 3 to 4 years. Why 3 to 4 years? Because the child should start to gain some continence before school age, which usually at 5 or 6, and also because of the waiting list. I could have said like at 4 years. However, we start the evaluation of the patient at 3 years because it takes time to do some investigations and to be on the list of operation. It takes time, maybe 6 months to have his operation. That's why we start at 3 years. If the continence is good, then well and good. If the patient is incontinent, and this is usually the case, we assess the capacity with voiding cystourethrogram and cystoscopy. So again, if the adequate bladder patch, we close at 3 months, then assess at 3 to 4 years old. Okay. After the assessment, we have either adequate bladder capacity or inadequate bladder capacity. If we have adequate bladder capacity, then we perform bladder neck reconstruction only. And again, this is not usually the case. If it's adequate bladder capacity, inadequate bladder capacity, we perform bladder neck reconstruction and augmentation iliocystoplasty, plus minus mitrofenov as a osteum for CIC. This is what I prefer, but it's not always that this is the preference of the parents. So sometimes we only do the bladder neck reconstruction and augmentation iliocystoplasty, and if the child fails to gain continence, then we do the mitrofenov, and it's usually with bladder neck closure at that time. Okay. What if we first see the patient and he has inadequate bladder patch? We do bladder closure only at the age of 3 months, not complete primary repair. Only bladder, if the patch is small, we prefer to do a complete, only bladder closure. And if the age is 3 to 4, and then at age of 3 to 4, we do bladder neck reconstruction and augmentation iliocystoplasty as the other scenario of the adequate bladder patch. What about the failed cases? We have failed cases, of course, and we see other failed cases from different centers, or sometimes we see a lot also from private practice failed cases. If the age is less than 3, we do bladder closure only and osteotomy. And if age more than 3, we do bladder neck reconstruction, augmentation, and mitrofenov. What about when you complete failure to achieve continence after multiple surgeries? We opt for bladder neck closure and mitrofenol, or sometimes we don't have the appendix or the patient performed already mitrofenol somewhere else, or even at our center, or gets obstructed or fibrosed. We then opt for a Monti diversion. This is a short history for the osteotomy. Osteotomy, first described by Trendelenburg in 1906 and Schultz, and posterior osteotomy later on came, and bilateral osteotomy of superior pubic ramus, and diagonal osteotomy of the iliac wing, and anterior innominate, and the combined anterior innominate osteotomy with posterior iliac osteotomy. Also, at our center, we passed through many stages in osteotomy. We used to do, some patients used to do posterior osteotomy, some patients used to do anterior osteotomy, and this also maybe in the 90s and early 2000s. Now, most of the cases, we do the anterior innominate osteotomy, and later on, recently, I mean, we tried to do, after discussion with the orthopedics at our center usually do the osteotomy, and we discussed that they do the anterior innominate osteotomy with combined posterior iliac osteotomy, however, from the same incision anteriorly. And this saves the patient, whenever you do a posterior osteotomy, you do it, you have to reverse the patient. However, when you do it from the same incision from in front, it's much easier. However, most of the cases we do the anterior innominate. Okay, what's in the literature about osteotomy? The average diastasis of the symphysis pubis is usually 4.8 centimeters. And when should you do osteotomy? You should do whenever the child is more than 72 hours, or even if he's young and the diastasis is more than 4 centimeters, and of course in failed repair. There are several techniques for immobilization: the modified SPACs, modified lines, spike casting, or mummy wrapping. At a recent EUA meeting, maybe the last or before the last, I heard a discussion between two big centers in the United States. Some centers do like a spike casting, and others do the modified brines, and they had like a quite heated conversation about which one is the best. So my advice is each center should do whatever is suitable for his circumstances. Even centers at the United States, some say like the spica casting is the best, and some say the modified brines is the best. In our center, we passed through stages. We did the spica casting, we did the mummy wrapping. Now we do like something else called pelvic binder, more like a mummy wrapping. However, it only compresses the pelvis. I will show it later. This is the survey regarding the osteotomy for 25 participants from this group. Around 60% said like it's a mandatory, and around 40% said it's optional. Okay, what we do here, as I said, this is our school. We do bilateral anterior innominate, and some cases we did the combined anterior innominate osteotomy with posterior iliac osteotomy at the same incision. We do this pelvic binder showed on the right. This is also after a discussion with our orthopedics at Cairo University, pediatric orthopedics, and they said like there is no use for retraction, and they preferred doing this pelvic binder. This is a recent study we performed at our center. It was the assessment of the anterior osteotomy role in restoration of normal pelvic floor anatomy of bladder exstrophy using preoperative and postoperative pelvic MRI. The aim of the study was to evaluate the effectiveness of anterior osteotomy in the restoration of normal pelvic floor anatomy in bladder exstrophy repair using pelvic floor MRI as an imaging tool. The study was conducted through 2 years, July 2016 and to December 2018. And infants with classic bladder exstrophy older than 3 months with no surgical attempts of repair were included. This is a pilot, a prospective randomized controlled study. Group A included complete primary repair with osteotomy, Group B complete primary repair without osteotomy, and Group C age gender matched control group included 6 patients. The usual preoperative and postoperative investigation was done, the data was recorded, the surgery technique was complete primary repair, and we did pelvic floor MRI preoperatively for all the patients and postoperatively after 3 months, and we did also for the control group. As you said, this is the technique what we did. Here are some pictures showing the technique of the anterior osteotomy. And these are the measurements that were recorded. It's a very complicated study. I tried to summarize it here. However, this picture or diagram shows some measurements we did. This study is under publication now, and these are the measurements. I want to concentrate here on the, I don't know if the arrow is shown, however, the green area is called the posterior bladder neck distance. The results, both groups were similar in all measurements, except the posterior bladder neck distance, which was in favor of the osteotomy group, which means that the osteotomy results, the group who did osteotomy was more closer to the control group regarding the posterior bladder neck distance. However, in all other measurements, there was no difference. The study concluded that osteotomy did not have a significant difference on the pelvic floor and did not have a significant role in restoration of the pelvic floor anatomy, and that repair of osteotomy did not add, also that repair of osteotomy did not add significant morbidity to the patient, no extra operative blood loss, or only the time was a little bit longer in the post-op in the osteotomy group. And we concluded that proper closure of the pelvis is paramount to success of the surgery, regardless we do osteotomy or not. However, this study, although we included this study, results concluded this results, we did not change our school of doing osteotomy whenever possible. We always do osteotomy only in cases where the pelvis closes when it's very malleable to close without osteotomy, but in most cases we do osteotomy. Regarding the continence, this is the continence of the literature. Successful primary closure is the main point for success or having continence post-op. What is the definition of continence? The problem in the literature that each center or each paper sometimes a little bit manipulated sometimes to report better results than the actual results. And there should be, there is of course a known definition of continence, that the continence should be the child should void through the urethra normally, having continence more than 3 hours, is continent at night. This is a child I call continent. However, sometimes you have to read carefully through the literature in order to understand what is meant by continence. The results for the complete primary repair only, the continence for complete primary repair, a child who have done complete primary repair only without bladder neck reconstruction showed at the Mansoura like 23%. This is excellent results. Regarding in the Mitchell group showed 17% only. So this is when a child does only complete primary repair. Regarding the bladder neck reconstruction after the complete primary repair, the continence might reach to 60 to 70%, although the bladder capacity should be more than 100 milliliter and up to 2 years to evaluate properly. And also many, as we in the literature, it's reported many complete primary repair require bladder neck reconstruction up to 80%. What about bladder neck injection? It shows good results following the bladder neck reconstruction, whether using deflux or macroplastic. Augmentation usually combined with bladder neck reconstruction. Whenever the bladder capacity is too small to perform bladder neck reconstruction only, we usually do augmentation cystoplasty. And if it's done after bladder neck, when the failure to achieve continence or safe bladder storage characteristics. The preferred augmentation for the bladder is usually the ileum. However, some centers use other segments. However, the ileum is the mainstay in the literature, usually at age 4 because it's no more risk for malignancy. What about the uterovesical implantation? At our center, we perform the bladder neck, we perform the uterovesical implantation whenever the ureters interfere with the bladder neck reconstruction. We do uterovesical implantation. However, we don't usually do it routinely. And you don't need to take a big patch. A small patch is usually enough because the size of the bladder usually depends on the matter of resistance, not the size of the patch you will take. What about the catheterizable conduits? As we said, we can use mitriphanov or young Monty. Whenever all measures fail, we do bladder neck closure. However, this does not count, of course, as continent regarding the strict definition of continent. But at the end, I see many patients very satisfied with the diversion of mitriphanov and are continent. This is our data regarding the continence and upper tract. This study was performed in 2015 and 2016, and this study was performed before the recent standardization of our protocol, the closure of after 3 months, the ischiotomies, and all of what I've said before. But this is represents some data that was collected in 2015 to 2016 and included 35 patients. The mainstay of this study was to concentrate on the upper tract. The age ranged from 23 months to 207 months, and the mean follow-up was 6 years. Age of first intervention varies from 24 hours. This is our all retrospective data, and as I said, all after before we standardized our protocol. And the mean number of surgeries each patient had undergone was 3.3. This table shows when the patients usually present to our center. As we can see, like many patients present even after 1 month. Like you said, like maybe 20 patients presented after 1 month to 6 months or even more. The idea when to close is not usually in our hands. Many times we see the patient who present late, especially in recurrent cases or referred cases. These were the results of the follow-up of this small group of patients, ultrasound and ascending. 70% did not show any dilatation regarding the ultrasound. However, regarding of reflux, many patients showed a grade more or less of reflux. These are the type of surgeries done for the 35 patients. Bladder neck reconstruction was performed like to 70%, augmentation like to 60%, bladder neck closure that was done for 4 patients. This table is not to show its main idea is to show that the exstrophy patients requires a lot of surgeries to achieve acceptable results. The continence, this is a snapshot in time. Like you cannot comment on continence. You have to. The patient should have undergone through all the stages of repair and passed the 5 years. However, these are the results whenever we collected the data, and it's not good results. And we have our reasons. However, we only achieved continence in like 14%, and this continence was not strict with the strict definition of continence, because a continent patient should void through the urethra without the need for CIC more than 3 hours. This is a very strict definition. Whenever we followed, we will find that many of our patients are incontinent or partially incontinent. So Again, this is a snapshot in time. You cannot really comment on incontinence unless you do the patient passes through all the stages, and we say like we now have our end result. However, this was a retrospective study, as I said before. These are some pictures for some patients. This is for a slide maybe for young urologists. We can achieve like an acceptable good result for a female introitus. And this is a result on the right side where we see the epitrophenoph stoma. And this is an ascending on the left with a good bladder capacity who did not do any augmentation. And on the right side, we see a very acceptable cosmetic for a penis with a history of bladder exstrophy. Here we can see two pictures for an ascending, one for very small bladder capacity on the left side, and on the right side after augmentation. How to improve? Again, as I said, the results I presented was in 2015 to 2016, and do not, this is what I call radical honesty, and it shows, doesn't show a good result. However, we did our best to do a better protocol, and we now made some differences. We prefer now the delayed closure. We unified the team. We are more, of course, towards osteotomy. We do adequate pain management and early discharge because of infection inside the hospital. Complications. These are the main big complications we can see. Bladder dehiscence or vesicocutaneous fistula. Not our center, everywhere we see it. Loss of urethra or pineal skin. Loss of gland space, we don't usually see it anymore. Maybe like 10 years ago or more, we don't do the complete cutting of the glands. We usually prefer to keep the distal glands attached and only detach the urethra and the spongiosum. Causes of failure, either wound infection, abdominal distension, loss of drainage tubes, lack of osteotomy with a wide pubic diastasis, or improper immobilization. This is a study done in 2019 and showed the role of anatomic pelvic dissection in the successful closure of bladder exstrophy and aid to success. Approximately 80% of patients had their urogenital diaphragm fibers completely intact and therefore did not have adequate pelvic dissection during their primary or secondary closure, putting the success of the previous closure at risk. So again, it shows the importance of the first closure. How to manage the fistulas post-operatively? Some fistulas close spontaneously. Other may require the gracilis or rectus muscle flaps. We only used maybe some rectus muscle. We know here that they lack adequate muscle at the lower end of the abdomen, so it's not usually easily to find to do a rectus muscle flap. However, some cases required. Sometimes you have to fix a nephrostomy if we have continuous leakage until the patient dries, especially post-operative. Failed closure, sometimes we see failed closure, whether it's our center or outside. And the optimum time to reattempt is usually 3 to 5 months after the last closure, as showed in a study by Gerhard, which shows his 50 years experience in management of failed cases. These are results from the same paper published in 2018, and they presented the results with 170 complete classic bladder exstrophy patients with more than one failed repair. Eventually, 97 achieved successfully closed, and the median time to success was 12 months. Did they do osteotomy when they did recurrent cases? Yes, and all of them had osteotomies. And here I want to say that osteotomy may be done more than once. Whenever a patient presents, we had osteotomy at the first time and comes again with a failed closure, you can do osteotomy, as shown here by the study. Like 75% had during their second closure, and 64% had during their third closure. How to avoid failure, post-operative immobilization, as I said, judicious use of osteotomy, subspecialty training, surgical training, adequate post-operative pain management as published by many papers. This is a slide I saw at the EOA. I really like it. They said, like Philip Ransley once said, I challenge anyone to show me an adult male with bladder exstrophy who voids normally, is dry day and night, and ejaculates and has normal sexual function. This is a real challenge. This is our reality. A paper published in 2018 showed used social media to assess the patient-reported outcomes, and it showed that many patients reported usually did not accept the results as previously reported by the surgeons. This is usually we see in surgeons report their own studies. Our study, what I have reported, which was done in 2015 and 2016, was done by an external resident, not from our center, and it was, as I said, radical honesty. And I have to say that most repair techniques are decades old. We have all the literature about old techniques and old schools, and we have this burden on our shoulders. We should come up with something to fix this miserable disease. What about the future? Is it about tissue engineering? There are some reports about composite cystoplasty. They use only the urethrium is engineered outside, and smooth muscle tissue is borrowed from in vivo. However, I see the future different. What we need is an open mind approach for management of bladder exstrophy, cooperation and teamwork. Open mind means like cooperation between centers, acceptance of failure, acceptance of to change your technique, acceptance to listen to each other. This is what I mean by open mind in scientifically. Proper registration and reporting, perseverance and patience, listening to the patient and the parents, psychological reports for patient and parents, and rehabilitation for patient and parents. The techniques are there. We have to improve and put more work at our technique and our follow-up and our listening. These patients are very miserable and require continuous care through adulthood. Thank you.
Thank you, Dr. Ahmed. Very, very illustrative lecture, and I admire the last slide too much. Although we fail in centralization of service for bladder exstrophy, but we hope for cooperation between the different centers, and we hope for making registration also for the cases. If we can do a national registry for bladder exstrophy and follow-up for bladder exstrophy from different centers, we can improve the outcome and results. Thank you, Dr. Shoukry, again.
Can I say something, please, before we start discussion?
Yes, of course.
Yes, we can. What we are doing now is a step in cooperation. The national registry is, of course, is a dream, but what we are doing, exchanging thoughts and listening to each other, is a start. As I can hear an idea from you or from any center, and we improve our results together. We should. This is a big step what we are doing now.
Thank you, Dr. Ahmed. I will leave the audience with Professor Mohammed Ghonaimi from Cairo University and Professor Ahmed Derwi from Asyut. But before Dr. Mohammed Ghonaimi and Dr. Ahmed Derwi started the discussion with Dr. Ahmed Shoukry, I announced for the next Tuesday meeting on voiding dysfunction and voiding school in children by Anne-Françoise Spinois from Belgium. And also the next Thursday will be Mark Sindron from Boston Children's Hospital, United States, speaking about VOR updated management. So next Tuesday, we will have Anne-Françoise Spinois. And after this meeting by 2 days, on Thursday, we will have Mark Sindron from the United States. So Dr. Ghonaimi, you have the microphone, and you have Dr. Shoukry, and you start your discussion. I see many questions needed to be clarified. Thank you. دكتور غنيمي. دكتور غنيمي. I will found Dr. Derwi.
I don't see
I
Dr.
think
Derwi.
I found him.
Found?
I found him. I found the Derwi now.
Till he come, Dr. Haytham, can I ask two questions, please?
Of course.
Dr. Ahmed Bini, thanks for this lecture. Please, I want to ask you about hernia in neonate before closure. What is your protocol?
Okay. Yes, sorry, I forgot to mention this. Unfortunately, we don't do the hernia repair at our closure. We do our repair only, and they usually follow up with the general surgeons who do the hernia. All of the cases of the hernia are done by the general surgeon at another operation, not at our operation. Maybe we should change this, but this is what happens.
My question is that at this time with Corona, we have 2 or 3 cases with hernia. We postponed the repair of exstrophy, but we obligated to do hernia repair this week. This is my question. So we do the hernia before the repair. This is the first one.
Okay.
Then when during my fellowship in Mansoura, they do hernia ordinary in the same repair by the same incision.
Yes,
and also as we are a pediatric surgeon, we face many cases of irreducible hernia after repair without hernia repair. So I highlight this point with you.
Yes, maybe we should change this. I'm saying what we are doing now. Maybe it's better to do this at the same incision. But what we are currently doing or practicing, that the hernia is done by the general surgeon at another operations. And whenever a child comes with a hernia with bladder exstrophy, after we do bladder exstrophy, usually the general pediatric surgeons who surgery department who manages these hernias.
Your opinion, Dr. Haytham?
Dr. Muhammad, I unmuted Dr. Muhammad Ghunaimi. Muhammad Ghunaimi? Dr. Muhammad Ghunaimi? The voice is not clear, Dr. Muhammad.
واضح ولا مش واضح؟ مساء الخير جميعا.
مساء الخير.
صوتي مش طالع برضو؟
لا طالع حلو كويس.
لا واضح واضح.
ازيك يا دكتور؟ شكرا جدا يا دكتور هيثم على استضافتي كمودريتور في السيشن دي، وخصوصا بعد المحاضره الجميله من الدكتور شكري، طبعا اخويا وزميلي وكل حاجه يعني. وطبعا هبقى سعيد جدا مع الدكتور احمد دروي ان احنا مودريت السيشن الاكستروفي دي، اللي واضح ان في ناس كتير قوي مهتمه بيها ومهتمه بتفاصيلها يعني. دكتور احمد
انا جاهز، ما فيش حاجه يعني
انا مش
مستني.
عارف الصوت واصل ولا مش واصل.
لا الصوت واصل تمام جدا. انا منتظر حضرتك هتسال الاسئله وهنجاوب. اعتقد افضل يعني حضرتك دكتور محمد غنيمي والدكتور احمد الدروي هم يعني يشوفوا الاسئله ويوزعوا الاسئله ويشوفوا يحبوا يجاوبوا على ايه.
احنا ما شاء الله واضح ان الشات لاين فيه كم من الاسئله كثيره جدا ليها علاقه بالاكستروفي، من اول البرايمري كير لغايه اخر حاجه الكونتيننت والدايفرجنس وكل حاجه. فانا هحاول جو ثرو الثريد لاين الاسئله اللي بتتسال كده. مش عارف الدكتور احمد معانا ولا مش معانا بقى.
دكتور احمد دروي مش ظاهر عندي، انا ظاهر عندي انت بتتكلم سامعك بس مش سامع حد تاني.
غنيمي, I tried several times to unmute Ahmed, but I couldn't unmute him.
طيب نبتدي في الاسئله لغايه لما ننجح ان احنا ندخله عشان ما نضيعش وقت الناس اللي معانا البارتيسيبنتس كلهم.
اتفضل.
طبعا هو الدكتور احمد بعد المحاضره بتاعته دي كان واضح الاسئله هتبقى كتيره قوي، لان زي ما كلنا شايفين ان بما ان الاكستروفي دي هو احمد قال كلمه لذيذه جدا في الاول، ان المالتيتيود اوف سيرجريز الكتيره اللي احنا بنعملها عشان نوصل بالتشايلد بتاع الاكستروفي ده للكونتيننس توضح قد ايه الباثولوجي ده صعب جدا، لان كل ما النمبر اوف سيرجريز اللي انت محتاجها عشان توصل للنتيجه المطلوبه بيزيد، كل ما يبان ان القصه محتاجه سبيشاليزيشن قوي، ومحتاجه تخصص قوي ومجهود كتير قوي. فاول سؤال هنبتدي نتكلم فيها، هنشوف الاسئله ماشيه في الثريد لاين كلها من اول الكير بتاع البلادر. اول سؤال، ايه الكيز فور البلادر كير في العيانين الديلايد ريبير؟ يعني في حد من الاودينس عايز يعرف لو انت مش هتعمل ايميديت ريبير وهنعمل ديلايد ريبير، الكيز للبلادر كير في الفتره دي اللي هي صراحه.
والله هي we do like we teach the patient how to manage or to manage this uncovered patch. We covered like with the tegaderm or like we use like zinc oxide cream for the macerations, and as much sometimes irrigation with a little bit of saline. It's not an easy task for patients, but we prefer this management idea of management of patients after 3 months. It showed better results in our hands, and especially post-operative management. The problem is not usually the surgery, the problem is usually the post-operative, regarding the nurses or regarding the pain management or regarding the immobilization or the anesthesia. So it's not about difficulty of the surgical technique, it's about post-operative management, and the management of the patch. It's not easy. Usually, like I said, the coverage with the tegaderm or some cream around the patch. Sometimes irrigation with saline if it's to avoid like يعني to get dirty يعني أو تتوسخ يعني. ف sometimes irrigation and zinc oxide is a good management يعني.
هو الدكتور احمد يعني اي ثينك ان احنا برضو انا كنت احب اعتقد ان الدكتور احمد جري بقى معانا دلوقتي، وكنت عايز اسمع احنا كما واضح ان زي ما احمد قال ان احنا الاكسبيرينس بتاعنا في جامعه القاهره ان احنا بقينا اميل للديلايد ريبير عن الايرلي ريبير. فكنت عايز اسمع الاكسبيرينس بتاع، هل في حد، انا عارف ان في جامعه المنصوره، مركز المنصوره هم اميل للكومبليت برايمري ريبير. احب اعرف هل في اسكندريه وفي الاتجاه ايه؟
احنا في اسكندريه يا محمد بنعمل delayed repair at age of 3 months وبنعمل المودرن staged repair of bladder exstrophy. اول الاكسبيرينس بتاعتنا من 10 سنين كانت السي بي ار اي او الكومبليت برايمري ريبير اوف بلادر exstrophy according to Mitchell. لكن في آخر 5 سنين we changed from CPRE to modern staged repair of bladder exstrophy at delayed time starting from 3 months with osteotomy.
واضح ان انتوا جابهتوا نفس المشاكل اللي احنا جابهناها، وده اللي خلاكم تغيروا زي ما احنا غيرنا من الكومبليت برايمري ريبير للمودرن ستيج ريبير، او لا. احنا بشكل مقابل يعني للمودرن ستيج ريبير.
حقيقي احنا هو احنا لما بدأنا بالكومبليت برايمري ريبير، لكن كان في آخر 5 سنين multiple reports about the ischemia of the glands and the loss of hemicorpora of the penis. And actually we didn't wait until we face a huge complication like this. And it is not related actually to dissection. It is not related to the surgeon. It is related to the closure of the pubic symphysis and what is called a compartmental syndrome, which happens with the complete primary repair, especially the neonatal time. So we shifted to the modern staged repair and delayed one at age of 3 months.
وانت احمد كمان دكتور احمد شكري ممكن توضح للاودينس الراشونال بتاعنا في الجامعه ايه اللي خلانا
انا عايز بس عشان ممكن في ناس عايزه بس اكد على شويه بعض النقاط ان ممكن يكون في ناس دخلت من النص. تاني احنا in short we do after 3 months we do complete primary repair, but it's a misnomer يعني مسمى خاطئ لما نفعله. بمعنى it's not a complete primary repair، لان المفروض complete primary repair يعني do one operation, which is not usually the case, which is mostly not the case. And the philosophy behind the complete primary repair, and we do a deep dissection of the bladder and the urethral plate. and we do complete penile disassembly and detachment of the urethral distal segment whenever we feel that this is a hindrance for dissection of the bladder. However, if we find that the bladder is deeply dissected without detachment of the urethral distal segment, we leave the urethra and for attached. However, we don't do like a bladder neck reconstruction. We only do minimal dissection or tightening at the bladder neck because it's not, we don't want continence at this stage. We want only successful closure. Later on, at 3 to 4 years, we assess the bladder capacity, and we do bladder neck reconstruction or bladder neck reconstruction augmentation or bladder neck reconstruction augmentation and multi-FNOF. And the slides will be shared, I think, later on or uploaded with the video, and it's more better to read it carefully and slowly. يعني.
هو ده بالظبط اللي انا كنت عايز اوضحه عشان للاودينس عشان يفهمونا. هو اللي احنا بنعمله بصراحه هو ما هواش ستاندردايز ابروتش في جامعه القاهره. احنا خدنا حته من ده على حته من ده. زي ما بنقول احنا وي ثوت ان الكومبليت برايمري ريبير كان كويس لانه بياتشيف كومبليت كلوجر، وقفل الابيسبيديوس بيدي للبلادر فرصه انها تجرو. بس كنا حاسين ان الاضافه بتاعت البلادر نيك ريكونستراكشن في الفيز ده بتزود الانسنس بتاع الكومبليكيشن قوي. فاكتفينا ان احنا نعمل مش كومبليت برايمري ريبير. احنا ما بنقفلش الاثيوبيا في وان ستيج، هي مش عمليه واحده عندنا، هي في عمليه ثانيه اسمها بلادر نيك ريكونستراكشن زي الستيج ابروتش اللي اسكندريه بتعمله بالظبط. بس احنا بنضيف على المره الاولانيه بس ان احنا بنعمل شويه بلادر نيك تايتنج وبنقفل الابيثيليوم عشان ان ذا هوب ان البروسيجر ده يزود البلادر كاباسيتي قبل البلادر نيك ريكونستراكشن. ولا مش ده قصدك برضه يا دكتور احمد؟
تمام. وهي فكره، هي دايما كل الستاديز بتقول ان الديب dissection of the urethra or the bladder into the pelvis is the most important thing or for success. That's why we believe that the urethra is part of with the bladder as one unit to be moved deeply. And I forgot to say about how we manage the female because it's not described well in literature. In the female, we do like a VY plasty for the vagina because the vagina is a little bit anterior displaced in female. We do a YV plasty under the vagina, which means we do the section in a Y shape and close it, because this also follows the same philosophy of putting the vagina and the urethra and the bladder as one unit deep into the pelvis. And in order to do this, we do a perineal YV plasty to push the bladder and the urethra and the vagina deep into the pelvis. In association, we standardize the osteotomy and standardize the immobilization in management. And as I said, it's we evolved with time. And we evolve each time. We have a deep conversation with other colleagues like you here. We listen to each other and learn from each other.
طب يا ترى
دكتور احمد شكري، دكتور غنيمي، دكتور احمد ديروي معانا اعتقد.
السلام عليكم جميعا.
ايوه
طيب، هو شكرا يا دكتور احمد على المحاضره الجميله. مش عارف صوتي مسموع
كويس قوي.
تمام. هو الكونسبت في البلادر اكستروفي ريبير، اول حاجه اللي انت تبقى بي هارملس. الطفل ده مولود بنورمال upper tract, normal genitalia. our effort should be to preserve the upper tract والgenitalia as it is. The other aim to be beneficial. انت تحاول تحسن الكونتنس بتاع الطفل ده. ومتهيألي دايما الكي زي ما الدكتور احمد قال اللي هو successful primary closure. وبأن الحالات قليله جدا، اعتقد ان من ضمن الاستراتيجي الكويسه اللي احنا دايما في الحاله دي يتعاقم فيها 2 بيدياتريك يورولوجيست، بحيث ان هو كده هيبقى جيننج اكسبيرينس اكتر ونقلل الليرنينج كيرف بتاع الحالات دي يعني. I totally agree repair اللي هو من 2 ل 3 شهور عشان خاطر فعلا ده more safe for children especially في our locality. بس احنا كنا حضرنا السنه اللي فاتت حاجه في الهند زي سيمبوزيوم للبلادر اكستروفي في احمد اباد. عملوا تقريبا في حدود 30 حاله بلادر اكستروفي within 2 weeks. الحاجه المختلفه عن اللي احنا بنعمله ان هم بيستخدموا external fixation مش هيب سبايكا. فدي كان very impressive.
ممكن اعلق على الموضوع ده؟
احنا مش سامعين دكتور احمد دروي لغايه ما الصوت يرجع. دكتور احمد شكري ممكن تكومنت
هو
على
دكتور احمد دروي كان بيتكلم عن ان هو كان حضر في اسلام اباد سيمبوزيوم عن 30 حاله اتعملوا في اسبوعين، وكان الحاجات الملاحظات اللي قالها ان هو كانوا بيستخدموا external fixation. احنا صراحه حاولنا نتكلم مع اساتذه العظام عندنا في الموضوع ده، هم ما يعني كانوا شايفين ان ما فيش فايده. خلينا نرجع تاني نتكلم بالانجليزي، انا اسف، عشان ممكن يكون معانا مشاركين هنا بالانجلش بس يعني. We talked to the orthopedic surgeons at our in Cairo University about the external fixation for management of osteotomy, and they were not enthusiastic about this, and they are the ones who told us about a pelvic binder is enough. And we started doing this pelvic binder in the past year maybe, and it shows good results, and we have a good results with it. Yeah.
دكتور غنيمي.
دكتور هيثم.
اتفضل.
طبعا لما دكتور احمد احنا اتكلمنا في نقطه التايمنج دي، واي ثينك ان احنا از ريجاردنج التايمنج بتاع الريبير احنا اتكلمنا في ان احنا عندنا نوعين من الريبير، الايميديت ولا الديلي. هو انا بس كنت عايز اضيف حاجه، ان الديليد ريبير من الحاجات الملحوظه عندنا في جامعه القاهره اللي فرقت معانا في الديليد ريبير، حاجات مالهاش علاقه خالص بالسيرجيكال تكنيك ولا ليها علاقه اصلا بالاكسترافي، ليها علاقه بالطفل ان جنرال. كلنا عارفين ان الكلام بيتكلم النيد للانالجيزيا بيفرق جدا مع الاطفال بتاعت الاكسترافي في الفتره البوست اوبرتيف، في ان انت تمنتين البلادر كلوجر وما ترفعش زي ما انت قلت الكومبارتمنتال سندروم، الانترا ابدومينال تنشن، كل ده بيكزرت تنشن على الويندو، بيخلي الكلوجر بيليد تو فيل كلوجر العادي يعني. وطبعا لما تتكلم مع التخدير تكتشف ان الامبورتنت بوينت in avoiding البوست اوبرتيف انالجيزيا هي البريزنس اوف الابيديورال كاستر. والابيديورال كاستر زي ما احنا عارفين في النيونيت is extremely difficult if not impossible. فعشان كده واحد من الادفانتجز اوف الديليد ريبير ده هو قصه الابيديورال كاستر دي مهمه، او الابيديورال انالجيزيا، ودي مهمه جدا في اول كام يوم بوست اوبرتيف، مهمه جدا جدا يعني. ثاني حاجه الكدني فانكشن، طبعا definitely الشيلدرن الكدني فانكشنز الايفولفنج بتاع يعني الايفولوشن بتاع الكدني فانكشنز في الفتره الاولانيه اللي هي من نيو بورن لغايه 3 مانث ماركتلي ديفرنت. انت كلنا عارفين ان الجي اف ار بتاع الشايلد ده بيدبل اولموست افري 2 ويكس، يعني انت الجي اف ار بتاع النيونيت بيدبل بعد اسبوعين وبيرجع يدبل تاني بعد اسبوعين تانيين. فديفنتلي الريسك وخصوصا بتاع الهيمودايناميك بالانس الفتره ان بريزنس اوف لو جي اف ار، اي نوع من النون كوركشن او البور هيمودايناميك ستيتس او الدي هايدريشن او حتى الستنت اوبستراكشن، ان انت تتعرض لفتره ستنت اوبستراكشن او كاستر بلوكج فتره النيونيت از اكستريملي هاي ريسك وممكن يليد تو ايرفيرسبل رينال دامج. عشان كده كل الكلام ده زقنا ان احنا نسيب شويه موضوع النيونيت ريبير ده ونزق شويه للديليد ريبير، مش مجرد النتائج الجراحيه او الباثولوجي نفسه يعني.
دكتور شكري. دكتور غنيمي. I see many participants speaking only in English, Dr. Ghunaimi and Dr. Shoukry. So we will speak only in English, please, if you can. Okay. Confirming your point, Dr. Ghunaimi and Dr. Shoukry, we have many problems when we did exstrophy in the neonatal period because the neonatal intensive care need in the post-operative period is very high. It is very, very, very important to have a positive anabolic state in the post-operative period. It is very important to have the immobilization. It is very important to have the analgesia and sedation. It is very important to care about the catheters and the ureteric stents and everything. And it's more demanding in the neonatal period. If compared to 3 months, 3 months period, the child is much, much easier to deal with after exstrophy repair in the post-operative period, which is equally important to the surgical reconstruction, I think. Shoukry, please, can you give us an idea about the care of the catheters and the post-operative care for children with exstrophy you do in Cairo University?
Yes, of course we do. We don't put a drain usually. We do suprapubic, 2 urethral catheters, ureteric catheter, I mean, sorry, and a urethral catheter. Usually the urethral catheter, I will remove it after 1 week to avoid obstruction and avoid infection. And I would leave the ureteric catheter as much as possible, maybe up to 3 weeks, and then remove one at a day and another at the second day. And the suprapubic one is the last to be removed. Sometimes the bladder patch is very small, and we don't do a suprapubic. We leave only ureteric and a urethral catheter. But the standard is a urethral catheter, usually like a small, very small 6 French, and 2 ureteric catheters, 6 or sometimes ureteric like 5 French or 3 French, and a suprapubic also like an 8 French. I would like to mention also a very important post-operative complication we saw, especially at the young, very young age in neonates. Some cases we had anuria post-operative, and this was because the high pressure of a very small patch and all of them resolved spontaneously, maybe after 2 to 3 days of management, and they had a high creatinine post-operative. And that was also one of the big reasons we delayed closure at 3 months, because the difficulty in management of such cases, and the very small patch and the high pressure from the edema and the ureteric catheter and the suprapubic and the urethral. And it's better to wait 3 months because of this.
Dr. Ahmed, one of the causes for anuria is the anesthesia management of these kids. That sometimes they didn't do good replacement of fluid blood during the operation, and this is usually affect the outcome of the closure because of the surgical edema and maybe essence.
Yes. Can I عشان in order not to to say that it's an anesthesia problem, this is exactly the point that I was setting. And these children at the age at the neonatal period, they have very labile kidney functions, and at the same time they have very labile fluid reserve. To state it's really difficult for the anesthesia at that time في neonatal period in order to undergo a big surgery. الفلويد replacement فيها, if you increase the fluid dose, you might go into pulmonary edema. If you reduce the fluid dose, you might go into acute tubular necrosis. عشان كده, in order not to put a lot of weight on the anesthesia, let's say that this period is quite a difficult period regarding the anesthesia requirement. Therefore, delaying the surgery till 3 months be safeguard anesthesia or be safeguard us surgeons on both sides. يعني ناحيتين يعني.
I agree, but you should have like fixed anesthesia team every time to get lessons from the mishaps happen to correct it in the next one. But I totally agree that delayed repair much safer for kids. There is a question, why you don't delay till 6 months instead of 3 months?
If I would answer, patients are very anxious, and there is no big difference between 3 and 6 months. There is usually a testosterone surge in the first month, and after from 3 to 6 months, there is no real benefit regarding the growth of the penis. So, and the patients are, and their parents mainly, are very anxious to close. That's why we prefer 3 months.
Okay. Osteotomy and continence in your Cairo series. This is a question from Mohammed Shimi.
Well, I cannot say that osteotomy, I don't have results to say that osteotomy did a benefit in continence or not. However, I can say that osteotomy is good has showed good results in post-operative success in closure. And as we provided in our study, as I said, it did not add much morbidity, or the only thing it added a little bit of extra time. So why not do it if it adds results in success closure? You cannot really comment on the effect of it on the continence because there are many variables regarding the continence, and you cannot pinpoint that the osteotomy is the cause of the continence or not.
Dr. Ahmed, and I have a point here. طبعا coming from Cairo University, and when I say an opinion that negates the trend that we're following in Cairo University, this does not mean that it's the operation or my the operation, the opinion of the institute. It might be my opinion. But just a question, Dr. Shoukry. We all know that the symphyseal diastasis recurs almost يعني universally بعد كل الاوستيوتومي procedures. And وفي two studies that studied the osteotomy زي Castagnetti and Mushtaq, which are both large working groups with exstrophy, and both of them showed that in the two groups, those who have done osteotomy and those who have not done osteotomy, there was no impact neither on the diastasis nor on the continence rate nor on the complication rate. And even Mushtaq had mentioned he did 75 cases without osteotomy, and the results were almost entirely as good as with osteotomy.
Okay.
In your results, why do you insist on doing osteotomy?
Well, as I said, the results of the under publication paper of the MRI, it did not show any big difference. However, this is our current protocol, and we cannot change it very easily until we have like a big discussion that we have now. In a recent consensus done at the USA, and regarding the survey I did today, but however it was on a larger scale of management of bladder exstrophy in the US and in the different regions of the world, and they showed that osteotomy is not very popular outside the US, and more or less was similar to the results of our survey. However, in the US centers, they prefer osteotomy. These are all schools, and a very important thing in reconstruction, especially, it's not usually, it's very difficult to display results regarding reconstructive surgeries because of the many variables. So whatever is good in your hand, do it. I would like to mention my father, Dr. Ahmed Shoukry. For example, when I talked to him, he said he never do osteotomy, and all his cases are doing more or less good. So it's whatever good in your hands. However, at ours now in Abu Rish, and we prefer osteotomy at this current stage of management.
طب وبالنسبه لجامعه اسيوط وجامعه اسكندريه؟
We use diagonal osteotomy and Asyut, but I totally agree that osteotomy usually cover like difficult repair. If you can do your repair without osteotomy and you are confident with that, it is okay. But for me, I do diagonal osteotomy. It is some sort of anterior osteotomy, but we go like between the anterior and posterior to make the pelvis more rotation, better than doing anterior alone, I guess.
دكتور غنيمي
الراشونال، عايز اعرف الراشونال بتاع الاوستيوتومي من دكتور احمد.
We do in Alexandria anterior innominate bone osteotomy like you are doing in Cairo. Dr. Gamal Saeed, Dr. Ahmed Shoukry is raising his hand for a question. I'm going to unmute him now to discuss with you. Dr. Gamal Saeed.
السلام عليكم دكتور هيثم. السلام عليكم دكتور احمد. السلام عليكم على الجروب كلهم، وكل عام وانتم بخير. I'm a pediatric surgeon. I'm learned a lot from Dr. Ahmed Shoukry from his comprehensive lecture. Just have a question and a comment. Who is doing this osteotomy, the orthopedic surgeon or the urologist? Number one. Number two, is the same osteotomy you are doing in the failure repair after that or not? Number three, if we, I think this is the aim of this nice presentation, nice meeting, is to learn our juniors and to our experience from the experts. I think يعني if presentation contain videos for the surgeries and the tricks of surgery and how to avoid the complication and how to get the outcome of the surgery, it will be more beneficial. Thank you all وكل عام وانتم بخير. شكرا جدا دكتور احمد.
شكرا. Regarding the first question, no, the orthopedics who do the technique, the osteotomy. The second question I didn't hear. The third question or comment, yes, maybe beneficial, yes, of course, to teach or to show some videos. But from my point of view, it's very difficult to learn such a difficult technique through videos, and sometimes such videos may like cause harm more than cause benefit, because management of bladder X-ray depends on many factors, and you should have first-hand learning experience, not to get a video and do it by yourself.
Okay. Another
Dr.
question
Onemi,
for
Dr. Derwi.
Okay. Okay. Timing of epispedias repair.
Okay.
So how early you recommend to do epispedias repair, and does this affect the bladder capacity?
Yes. Regarding our current protocol, we do the epispedias repair with the primary repair at 3 months. This is our current protocol now.
Okay. And how to avoid the compartment syndrome, which is very crucial to genital injury for the glands? If you have any tricks?
You mean by compartmental syndrome when you do like a disassembly and you see like the glands changes color, or what? Please explain more.
Yeah.
Well, I cannot say a trick specifically, but you see it firsthand when a gland changes its color. You usually cut the suture you took. You have to be careful, and I cannot explain it. I don't have a trick to recommend especially.
And sometimes you can do like fenestration at the glands, like by knife, and if the blood is going fresh, you are okay. Otherwise, if there is no blood coming, this is very dangerous. Okay, and then you have to redo the symphyseal stitches again. Agree.
I would like to mention something, please. I forgot regarding the closure, because sometimes I said sometimes we close without osteotomy. However, whether we do osteotomy or we don't use osteotomy, we use a PDS suture for closing of the symphysis. Previously, maybe before 10 years ago, before 2010, we used to use sometimes wires. Sometimes we used Prolene back in the early 2000s and the 90s. However, now we never use wires or we use Prolene. We saw maybe starting after these many cases were done with wires or Prolene closure at the symphysis, we saw many post-operative complications regarding erosion or bladder stones. So we stopped using. We only use a PDS, sometimes Vicryl if it's not available in the PDS, and we take very careful when we close the symphysis and approximate it together. We put like something to avoid that a suture is eroding through the bladder or the bladder neck, and this is puts importance on the radical dissection of the bladder and the urethra as a unit deep to the pelvis, so to avoid whenever the symphysis comes close together with its sutures does not erode into the bladder.
سؤال يا دكتور احمد شكري، معلش، وانا عجبني جدا واحد من الاسئله اللي اتسالت ودي مهمه قوي. how many times does it take قبل ما اقرر ان الكلوجر is not possible and the diversion is necessary؟ ودي will take us back to the decision that you said before. You said that you assess the patch at 3 months or at the neonatal period to assess the quality بتاع الباتش, if it can be closed or if it can't be closed. What if you come back after 3 months or even after 6 months and you find that the quality of the patch is still bad? It's still a small patch and it's still not feasible to close it. What do you do at that time? Do you still insist on closing it?
Yes. Whenever a patch is very small, I said we do only bladder closure. And of course with osteotomy. And usually the bladder, even it looks ugly, if it's a fresh case, it can be closed. You can remove some polyps and you close it and it goes well. What we are talking about here, the complication of a failed case, when you see a completely destroyed patch and devoid of any healthy tissue. Sometimes whenever you see a recurrent case who have underwent many surgeries, might be the good decision to make is to do a cystectomy and augmented pouch and multifonov and bladder neck closure if the patch is very bad. Some centers, I read about some papers, they do whenever the patch is very bad, they do and they want to avoid augmentation at early age, they do uterosogmoidostomy for a couple of years, and when the child grows up, they do a cystectomy and augmentation. There was a question in the chats regarding what's the optimum age of augmentation. We do it usually, we start to assess the patient at 3 years, and usually by 4 he had underwent an augmentation eosoplasty.
اللي انا فاهمه من كلامك ان every patch deserves to be closed no matter how bad it looks like. صح؟
If it's a first time to see it, it's usually closed. If it's a fresh case.
الدكتور هيثم والدكتور احمد الدروي متفقين مع الرأي ده؟
I agree because it is, if it is primary closure and the bladder is very small, I will give this patient a trial. But for redo cases, it is usually very difficult. Sometimes I give testosterone first and wait for at least 6 months and then give another trial if the family is cooperative. Otherwise, it is better to do with augment or urine diversion.
And in such case, برضه الاكسبيرينس السؤال, when do you decide to do augmentation سواء في اسكندرية أو في أسيوط? What is the optimal age that you would consider in doing an augmented pouch or a reservoir and getting rid of the bad patch?
Ghunaymi, concerning age in Alexandria, we start thinking of doing augmentation for small bladders after successful primary closure at age of 5 years, not before.
Maybe I have like more delayed at augmentation, at least 8 years, because most of patients in Upper Egypt come from poor family and they don't have like free access to healthcare, and I have to like educate the mother very well. So I think 8 years will be more safe.
I'm not talking here about elective augmentation, if you understand me. I'm just talking about what if you're forced to do a procedure that either removes the patch or augments the patch. What if you're forced into this situation? What is the option that you would go for? Would you augment or would you go for a diversion?
You mean for failed closure?
For failed closure.
Okay, I think I will wait. Yeah, I will wait. I don't, because he will be incontinent anyway. So if I decide this bladder will not be benefit from another trial of closure, I think I will wait. Till urine diversion.
Muhammad, we are always trying to close the bladders. We are always trying, like you in Cairo, to get a chance for the bladder closure. But upon failure, we would think in doing the augmentations. But if we decide to do augmentation, we delay the time of augmentation. We don't do augmentations prior to age of 5 years.
Okay. So another question for the bladder neck reconstruction, the type and result, and do you use Mitriphanov with it, Dr. Shoukry?
Yes, we do. Whenever we do, to put things in perspective again, whenever we do a bladder neck reconstruction, it's usually at the age of 3 to 4 years of age. And if we have a good bladder patch, we do it. If we don't have a good bladder patch, we do it in association with augmentation and Mitriphanov. And this is the standard care. However, the Mitriphanov decision is a very big decision for the parents, and they have difficulty in understanding how our child would have a stoma in his stomach or in his belly. So sometimes it's very hard to convince them, and we usually do augmentation and bladder neck. Regarding the type, we usually do the young Ledbetter technique, young D's, and that's it.
Okay, another question, if you are going to choose between tightening of the bladder neck versus closure, which one do you prefer?
Again,
if you choose closure, how you deal with Mitriphanov dysfunction?
Again, please.
If you choose between the bladder neck tightening or bladder neck reconstruction, make it very tight versus closure, which one do you prefer? And
okay.
if you choose closure, how you deal with Mitriphanov dysfunction?
Okay. We always push to we see that every child deserves a chance to have voiding through his urethra. So whenever we do the bladder neck reconstruction, we do a tightness as much as possible, and we do a Mitriphanov with it. If it failed, sometimes we have like a suprapubic fistula or penipubic fistula. We give it another chance for repair of the fistula. If it failed again, we opt for bladder neck closure. And a bladder neck closure, it's not an easy operation at all. It's easy to do. However, its results are not perfect. Even if we do bladder neck closure, we sometimes get leakage, and this can be managed. Sometimes we have to do nephrostomies temporary in order for the leakage to stop. Regarding the Mitriphanov, it has its problems too. Sometimes we have retention and failure to do CIC by the child. And sometimes we need to do a cystoscopy or maybe a ureteroscopy using a small caliber or instrument to get through the stoma of the appendix. Sometimes the appendix is, you can find an appendix if it's got devascularized or sometimes it get fibrosed. Sometimes the stoma is fibrosed or closed. There are many complications regarding the Mitriphanov as any reconstructive operation.
Dr. Derwi,
audience, Dr. Ahmed.
Dr. Ghanemi. Dr. Ghanemi, can you say your experience regarding the same issue of bladder neck surgery or bladder neck closure in children with exstrophy? I'd like to hear Dr. Ghanemi and to hear Dr. Derwi, please.
Okay.
بالنسبه للكايرو يونيفرسيتي اكسبيرينس، هو دكتور احمد كان واضح جدا في عرض نقطه في اللاست سلايد عن الاكسبيرينس بتاعنا. احنا ال only patient in which we, او majority of the patients in which we achieved real continence فيهم بس مش continence through the urethra زي ما الدكتور احمد قال are the patients for whom we did bladder neck closure and Mitriphanov procedure. زي ما الدكتور احمد قال البروسيجر بتاع bladder neck closure is not easy خالص. Many of these patients come back voiding او incontinent per urethra post bladder neck closure. فالprocedure itself requires a proper dissection of the bladder neck, creation of a big distance between the closed reservoir and the urethra, or you'll get leakage per urethra if you have a leakage. Somehow urine finds its way back to the native urethra in a way we don't understand يعني. Sometimes we need to go back and put a nomental patch or even peritoneal patch to stop leakage. Recently, this is a recent updated patch, and the problem with the leakage we're facing sometimes necessitate placing nephrostomy to achieve dryness or to avoid the leakage ده في البوست operative period. We found it's related mostly one of two things. Essentially للvascularity بتاعت البلادر patch مش للintestine which we use at that time to augment. And usually الباتش following bladder neck closure البلادر patch دي تبقى relatively ischemic. فالهيلينج باور بتاعتها بيبقى delayed شويه requiring stenting for a prolonged period. That's why if you ask us how long, if you ask Dr. Ahmed Shoukry how long we leave urethric stents and suprapubic and the Mitrofanoff channel catheter, we try to leave them as long as possible to achieve a relatively dry pouch for a prolonged period. لأن احنا already we know that the healing power بتاع الباتش دي is quite delayed.
Dr. Derwi?
Okay. Usually you go for bladder neck reconstruction. I think it is like safety way to access the bladder. So whatever I could do bladder neck reconstruction, it is much better. For if I'm going to do bladder augment as well, I think this should be very tight bladder reconstruction because my aim here to make this child dry, not continent. For the bladder neck reconstruction, which I usually do at the age of 4 years, for the good bladder patch, I usually make it like bladder funnel because our aim to volutional voiding. But for this bladder neck tightening with bladder augment, I usually make the ureter like cranial mobilization and make very long bladder neck, very tight one, over 8 French or even 6 French catheter to make the child dry. And usually I combine this bladder neck reconstruction with SIS or tonica vaginalis to avoid any fistula. If this fails, I usually go for closure, but this is my last resort. Usually I like the bladder neck reconstruction better.
Can I have comment, Dr. Shoukry?
Of course.
In Alexandria, we are not so optimistic with bladder exstrophy like you are in Asyut and even in Cairo University. We distinguish between two categories of children with bladder exstrophy epispadias complex. In isolated epispadias, in incontinent isolated epispadias, we do bladder neck reconstruction type Mitchell. And we have children who are continent, who are dry and voiding normally per urethra. But in the other part of the scope, which is exstrophy complex, actually at age of 5 years, we didn't up till now have any child who is voiding normally per urethra. And so our approach is to do bladder neck reconstruction Mitchell, which is a tight bladder neck reconstruction over 6 French catheter. And we do combined with the bladder neck augmentation and the Mitrofanoff appendicovasectomy in all our cases. So in bladder exstrophy, we never in Alexandria did only bladder neck and the Mitrofanoff. We usually do bladder neck augmentation and the Mitrofanoff.
Okay. Even for like good bladder, if the bladder capacity like
we didn't have it, Dr. Derwi, in Alexandria. Of course,
no.
We didn't see it until now. We didn't see it.
In Mansoura experience, the Dr. Ashraf Hafiz just published it. He have like 25% primary continence and another 12% after bladder neck reconstruction. And he used the CPRE, the Mitchell technique for his closure.
Thank you.
Okay, another question for the rule of autologous sling or artificial renal sphincter to achieve continence after failed bladder neck reconstruction, Dr. Shoukry.
We don't have experience in using artificial sphincters in bladder exstrophy patients. However, regarding we did the slings, we did some cases. We used a rectal sling, and it showed promising results. Some cases we did an autologous sling using the rectal sling.
Okay. I think the last question, the difference in bladder pressure after puberty in good bladder capacity regarding the timing of bladder exstrophy repair. I think he may ask about the delayed repair versus early repair. Does the bladder pressure like make difference after puberty?
I don't really understand the question, but
very hard one.
I don't really understand really the question, but in general, I think a blood pressure can be measured in puberty using a urodynamics very easily, and the blood pressure depends on the size of the patch or side of the bladder, and you can see by the ascending if the bladder is small or strained, and if you have any doubt, you can use urodynamics in puberty very easily.
Yeah. Okay, I think we have no more questions.
Dr. Shoukry, please, I might add something. Dr. Shoukry, might be the question of puberty is asking about the effect of growth of the prostate on the continence in those children with bladder exstrophy, that you might not need to do anti-incontinence surgery and just wait until puberty. What do you think?
Yes, this is a leading question, Dr. Haytham. And yes, it's true. I saw recently many patients. I think after this lecture, I would start to do another study for the recent 4 or 5 years to present our recent results. However, I really see many patients now presenting with acceptable continence, not totally continent, however, acceptable social continence. And I saw them and I told them, wait for a couple of years. Maybe when the child grows up, he might get continent, because sometimes whenever you try to achieve 100% continence, you might do worse. You go to fight for this dribbling and you might turn the patient in a worse condition. So I advised many of them to wait until they grow up, because sometimes the prostate or whenever the child grows, and there are some published papers on this, he might gain continence by time.
But the prostate
usually قبل ما ننزل على one of the techniques، انا ملاحظ ان احنا both centers او معظم السنترز في مصر are moving between a stage repair and complete primary repair. وحتى الدكتور احمد في محاضرته he listed these two as the two main techniques, and then we dropped another technique which I think we should give a chance to, لان النتائجه in selected hands were quite okay. I think Dr. Haytham was one of the doctors who visited Manchester, and I think they are doing the Kelly procedure, and the Kelly procedure is quite a sophisticated and demanding procedure, and yet it's one of the techniques that allows the return of the bladder properly back into the pelvis, and recreation of the pelvic ring, a proper pelvic ring with the closure of the levator around the bladder, which is the rationale for further continence. Can I hear the opinion of 3 different people, like Dr. Haytham, Dr. Shoukry, Dr. Derwi, about the Kelly procedure and why it never got a chance to be adopted here in Egypt in any of the centers working?
Dr. Derwi? Dr. Derwi, you can answer, Dr. Derwi.
Okay, so I am afraid to do this because it make you doing a lot of dissection and may endanger the genitalia. I learned the medical technique because I stay in Seattle for 2 years, and I'm confident with this one. I think Kelly, if you want to do Kelly, you should have training for at least 2 years in a specialized center. Otherwise, you will make a lot of harm for these kids. But this is very interesting technique. I think in London they use it a lot, and also in Regensburg. Yeah, in Regensburg. in Germany, but you should train for it. Yeah.
Dr. Shoukry?
To be honest, I don't know how to do the Kelly's technique. I did not see it firsthand by my own eyes. I saw some videos, read some papers, and until now, I'm now an associate professor and I don't understand it. And I have to visit a center to see it by myself. And I always do what I can do. I don't experiment in patients.
Can I comment on the Kelly, Dr. Ghanemi?
Yes, sure. I want to hear your opinion.
Yeah, I did about 4 or 5 cases Kelly procedure in males and also in females. But at the end of the day, the technique is very demanding, sometimes dangerous to the neurovascular bundles, especially in the male. The dissection is not easy to understand and to proceed, and also to mentor for young fellows and colleagues. And you have to ask yourself at the end different questions. Number one, is there any difference regarding the outcome of the primary closure between Kelly modern staged repair and Mitchell CPRE technique? The answer is no. They have the same outcome regarding the primary outcome of closure. Again, is there any difference regarding the continence state between the Kelly and the CPRE and the modern staged repair of exstrophy? Until now, it is not proved any superiority of doing the Kelly procedure. Number 3, is there any effect for the Kelly for benign lengthening, like they were saying that it causes an increase in the length of the penis compared to the Mitchell and compared to the modern staged repair? Yes, on table, at the end of the Kelly procedure, you will find a large lengthy penis because you detach the crura completely from the inferior pubic rami. But during follow-up, retraction again of the penis occurs, and the length of the penis became like the length of the penis in the CPRE and length of the penis in the modern staged repair of exstrophy. So my question at the end, what is the benefit of doing such a hugely demanding procedure?
Okay. To improve the length of penis and CPRE, usually
على الرد ده ممكن كمان على الرد هو let's start about the continence issue. We all know that the continence achieved early is not the continence you get after 10 years.
We don't hear you well, Mohammed.
Is quite apparent في النتائج الcontinence. The big studies, our big centers working with the CPRE, I think that the continence that you get in the early period is not the continence that you get after 4, 5, or 10 years. This is evidence من the long-term continence results that a big study. Early on, Gerhardt to Mitchell said that they had continence rates of 70 and 80%. But when these patients were followed up into adolescence, the continence rate declined down, not stopping even at 50% or even lower يعني. فالموضوع الكونتيننس ده is very difficult to assess for multiple reasons. The definition of continence مش standardized, the observational period مش standardized, كل الكلام ده مش standardized. عشان كده everybody assesses his continence in his own way. As you can see, when Dr. Shoukry presented our experience in Cairo University, he said that the only patients that we had truly continent were 5 patients with a bladder neck closure. The majority of the other patients were partially continent. قصة partially continent دي is really هو الدومين اللي بيكريت ال different interpretation للresults, as we can see في كل ال studies. Because we all know that there's something called surgeon bias. Every one of us wants to have a technique that is producing real results. But unfortunate to say, I really haven't seen, and I've seen a lot of patients done inside Egypt and outside Egypt, repair for bladder exstrophy, and a true continent child following repair of bladder exstrophy, a true continent child, not a partially continent, a slightly continent. A true continent child is a rarity, a real rarity, as we can see.
Me neither.
The idea that this technique, I can quite say that up to now, we haven't evolved. In the last 20 years, there has been no real jumps in the surgery regarding exstrophy. برغم ان الكونتيننس rates are not that good. ولا مع الميتشل ولا مع الكومبليت ريبير ولا مع الستيج ريبير. That's why when I said that there are people visiting the Cali repair, I'm saying that we should all open our mind looking for another procedure or maybe an innovation in the procedure اللي موجود دلوقتي for better results. Accepting the old results or believing that we might produce better results with the same technique is a little bit silly, because if we all believe that we are different surgeons than the surgeons that preceded us, this is not true. We are as good as our surgeons, and if we don't change the technique or change some parts of the technique or look for a new technique, then we'll stop at the same results that were there. This my idea is not because the Cali procedure and I'm an advocate for the Cali procedure ولا حاجة. I'm just advocate to the idea ان احنا we don't surrender to all the procedures that haven't really achieved good results. And we are in need for innovation, even في procedures القديمة or in new procedures. لأن apparently these old procedures ما حققتش النتائج المطلوبة. What I'm saying is that new procedures need to be given a push. والتكنيك اللي apparently seems difficult with training and with effort might in the long term become an easy procedure. عشان كده بقول ان الكالي ممكن ما يبقاش دلوقتي ليها value، لكن يمكن لما تتجرب في برود في multiple centers و longer term results it might achieve better results. خصوصا كمان ان التكنيك theoretically appears very sound بنظريه ان هو بيرستور النورمال اناتومي او بيحاول يرستور النورمال اناتومي. انا مش عارف هل اغلبنا عمل حالات ريدو بلادر نيك ريكونستراكشن وريدو كلوجر لاكتوبيا، and we all see that even with our greatest effort ان احنا نقفل البلادر نيك وان احنا نرستور البلفيك اناتومي، وانت داخل تعمل الريدو بروسيجر you find still that الليفيتر اناي بتبقى سبلايد وستيل ان السنتيزا ستيل بعاد عن بعض، which means ان احنا التكنيك اللي احنا بنعمله does not really achieve restoration of real pelvic anatomy. مش عارف الكومنت بتاعكم على الكلام ده ايه.
محمد, we will hear Mark David Leclerc in a separate lecture speaking about the Cali and the results of the Cali procedure, as Mark David is one of the popularizing surgeons for the Cali procedure. We will host him with us. دكتور محمد سعدة. دكتور محمد سعدة.
ايوه دكتور هيثم مع حضرتك.
اتفضل.
بعد اذنك بس دكتور احمد، هو بس لما جه اتكلم على الواير قال ان شفنا من وراه حالات ستون بلادر، فانا مش فاهم دي.
تاني زي ما قلنا احنا التكنيك بتاعنا ايفولف. الوايرز كانت كلوجر اوف ذا سيمفيسيس بيوبز او ابروكسيميشن اوف ذا، حتى لو انت بتعمل اوستيوتومي. sorry I will speak in English. When you do osteotomy, you need to approximate the two symphysis pubis. We used to use a wire to approximate the symphysis pubis.
I know we do this, but what is the relation to stone?
I will tell you. If the bladder is not adequately dissected down deep to the pelvis, we saw that the wire eroded through the bladder, and we saw stones on the wire into the bladder, and we saw this also with using proline. However, when we used PDS or Vicryl, this did not happen. I know you would tell me if a wire erodes through the bladder, this means that there was no adequate dissection. I'm telling you the results. After a couple of years of using the wire and proline, we usually saw penopubic fistulas and erosion through the bladder. However, the use of Vicryl or PDS or the more rapid absorbable sutures, we did not see this. This is just our recommendation.
Observation, yeah.
Yes.
يس انا برضو حضرتك لما الدكتور اتكلم على البلادر نيك ريكونستراكشن وقال ان فعلا هي ات از فيري ديفيكالت اوبريشن، انا بعيد هنا كلام الدكتور اشرف حافظ. قال مره ان الحاله اللي عملها ميتشل هنا في التسعينات في مركز غنيم دي جالها رينال فيلير عند سن 18 سنه. ده فيرست كيس دان ان ايجيبت. فده برضو ياكد ان كلام ان حضرتك ان الموضوع فعلا محتاج يعني مور انفستيجيشن اند ما نبقاش احنا هاري ان احنا نقفل البلادر.
هتوصل بلادر نيك كلوجر، توصل بلادر نيك كلوجر.
بلادر نيك كلوجر
مع بلادر نيك كلوجر معاه مترفونوف، ولازم يبقى العيان the patient should be aware that when we do bladder neck closure he requires a rigid follow-up schedule, and whenever he feels you have to know that the best one who can do a CIC is the patient himself. And they are usually very small kids, and they are perfectly doing CIC, and they know their way, and they are the first one to report that there is a hemorrhage or they cannot do a CIC, and they come in emergency, or they come عايز اقول على طول يعني to present immediately to our department, and we do them cystoscopy or revision sometimes to the stoma. It's very difficult, but I saw some adolescents and adult patients with bladder exstrophy, and they are living with the diversion very happily and satisfied. And you cannot, I cannot tell you, of course you saw, but I want to tell the audience that achieving continence in bladder exstrophy is a dream for every patient before the surgeon. And whenever they achieve continence using this stoma, they are very happy and very satisfied, and they care much about their stoma to keep it competent. And whenever they face a problem, they present immediately. So whenever we see a back pressure or retention or renal failure, this is failure to follow up or failure to present to the department.
Yes.
It's not a failure of technique.
Yes. My last comment or question, please. I want to know your experience in colorectal exstrophy. As this one of our as pediatric surgeon problem, and they have bladder exstrophy, as you know. Your experience with it.
My personal experience, I have limited experience, but maybe Dr. Muhammad has a better experience than me. I have limited experience in colorectal.
معلش ما سمعتش
دكتور غنيمي.
معلش سمعت السؤال تاني.
Your experience in cloacal exstrophy.
Bladder port or bladder portion. I ask you about the urologic only in cloacal exstrophy. Your experience.
Unfortunately احنا في العصر العيني we refer the cases of colorectal exstrophy للجنرال surgery because as you know or pediatric surgery يعني because you know that the majority of the work with the pediatric surgeon بيبقى involving الcolon.
Yes. After that, repair of bladder. You do it or let pediatric surgeon to close it. This is my own question.
Usually البيدياتريك surgeon ما بيرجعهم ليش.
يعني حضرتك نوت سي كيسز دكتور هيثم. معلش
we are the same محمد. we don't see the we don't see the colorectal exstrophy. Usually our colleagues in pediatric surgery do it. I don't know Ahmed Derwi in Asyut what he's doing.
I usually do the unification of the hemibladders, and then the child usually die before the
No at all. We face many cases and they are living till adulthood. No problem.
Okay, but if you use colostomy, if you use ileostomy,
we must do colostomy. We must do colostomy.
You lose a child. So
no,
I agree.
Firstly, at emergency, we do colostomy for this baby and take out the GIT portion between the two hemibladder and make it one bladder. My question to you, after doing that, you have any recommendation for better prognosis after that, or as we do?
Because this child has a high risk for compartment syndrome too.
No at all. No at all, Dr. Ahmed, please.
You just make the hemibladder closure, and then if there is like exomphalos major, you may put SIS as well. Okay, to avoid the compartment syndrome. And then if the child survives, you can
survived, Dr. Ahmed, please.
Okay.
This point, I ask you about the urologic problem, not only. He is survived.
Okay.
We deal with exomphalos, we deal with the colon. no problem. But my question is urologic problem. There is any modification or any recommendation or no?
Okay, so the same, but usually this child has also neurogenic element. So the evolutional voiding is very unlikely for these kids, and usually you go for bladder neck reconstruction or closure with augment at the end. And sometimes the bladder is very huge, and you just do bladder neck closure and mitriphenol.
Yes, this comment because I start with asking about hernia, because in our duty as the pediatric surgeon, I learned in Mansoura we must do hernia as a routine during bladder exstrophy repair, and we faced many cases closed the bladder exstrophy without hernia, and after that coming with incarcerated hernia and lost loops after repair. And the last question I said about colicus exstrophy, as I learned in Shams University, and you know the pediatric surgery there, they are have the Center of Pediatric Urology and doing this frequently, and I see this, and so this is my 2 comments. Thank you, Dr. Ahmed.
Okay, I agree that you should do hernia at the time of bladder closure, which is very easy. You go like extra peritoneum.
Yes.
Very easy. Another comment for Dr. Ghonaimi about the like we have like to wait very long to evaluate the success of the repair, because in the Jeff procedure he started 1971, and then after 20 more years Mitchell start his procedure. So it takes very long time to evaluate this kind of rare diseases and the outcome of surgery. But we have a lot of modification now, because we usually go now for delayed repair, which is, I think it is very safe and good achievement. Also, we don't have like good tolerance to make the urethra at the tip, because usually it makes the penile shaft kinked and short. For myself, I usually go for hypospadias for these kids in most of time. The other thing also that the ventral rotational skin flap of baby Sally, which make the penile shaft looks better and avoid the dorsal midline scarring, which make recurrent cordy. I understand that the regard continence, we didn't make such like huge difference, but like regarding safety of surgery, I think now it is much more safe, and the result of primary closure and success of primary closure much better than before.
Dr. Ahmed Shoukry?
I share with
Dr. Ahmed Shoukry?
No, nothing more to say. I agree with what Dr. Derby said, and we usually also do the hypospadic more. And there is some, of course, the acceptance to delay the closure is a good step. The acceptance to do augmentation, and the acceptance that the CAPRE is not a final destination. These are all steps. But I also agree with Dr. Ghonaimi. We might need a radical approach for or to open our minds for a new way of thinking. There is a problem, and we have to come up with a new way. We are living on the past now, and we have to come up with a new way.
Thank you, Dr. Shoukry. Thank you, Dr. Ghonaimi. Thank you, Dr. Derwi. Thank you, Mohammed Saada. Thank you, everyone participated with us.